Good morning. My name is Dr. Ashan Canagasingham, and today I will be discussing how reliable is the maximum flow rate measured during urodynamics. This study was performed in affiliation with the Concord Repatriation General Hospital and the Royal Prince Alfred Hospital in Sydney, Australia. Urodynamics, along with pressure flow studies, are the gold standard for diagnosing bladder outlet obstruction. Routinely, the study begins with a free flow study, followed by the catheterized pressure flow studies. The literature suggests that there are differences in pressure flow and free flow studies' Qmax values for reasons such as muscular or urethral sphincter spasm and geometric impacts of the catheter on the urethra. However, the difference and significance is not well quantified. Some centers use single lumen channels for both filling and transducing. Others use two separate tubes. At Concord Hospital, two catheters are inserted, a 14 French catheter for bladder filling and a 5 French transducer catheter for measuring the vesical pressures. At the time of voiding, the filling catheter has been removed and only the 5 French transducing catheter remains. A prospective study was performed, including men with localized prostate cancer awaiting radical prostatectomy as part of the ROSE study, with complete urodynamic data sets, looking at the Qmax, voided volumes, and residual volumes in the uroflowmetry and pressure flow studies. There were 71 patients with a mean age of 65. Using the Bladder Outlet Obstruction Index, the study showed 32% of the patients were obstructed, 24% were equivocally obstructed, and 44% were not obstructed. The most significant and clinically useful finding was that the Qmax was most reduced in obstructed patients undergoing pressure flow studies at a mean difference of 3 milliliters per second. The equivocally obstructed group is often the most interesting and most challenging group of patients to accurately interpret their urodynamics. When interpreting the results of patients in the equivocal group as per the Bladder Outlet Obstruction Index, the study shows that if there is a difference of at least 2 milliliters per second between the Qmax of the uroflowmetry and the pressure flow study, then the patient is more likely to be obstructed. This added piece of information can assist in the management of these patients. The voided volume of the unobstructed and equivocal groups was significantly greater than the obstructed group during the pressure flow studies in comparison with the initial uroflowmetry. The post-void residual volumes of these three groups were also higher but less significantly different after the pressure flow studies in comparison with the uroflowmetry. It is important to note that these differences may be affected by the mechanical filling of the bladder during the urodynamic study. Catheterization as part of urodynamics has a significant effect on the Qmax, voided volume, and post-void residual volume. Qmax in the obstructed patients is affected the most, with a mean difference of 3 milliliters per second, or 25% less in the catheterized group compared with the non-catheterized group. When establishing whether a patient is obstructed, it is important to bear in mind that the free flow Qmax and catheterized Qmax are not equivalent. If the transducer falls out during the pressure flow study or the patient knocks over the flow meter, the free flow alone should be used with caution in calculating the Bladder Outlet Obstruction Index. Thank you for your time.